Great. Thank you, Mark. Well, I'm going to be talking, even though I do HIV as well, I'm going to be talking about hepatitis C. I'm Andy Ustianowski, I'm from Manchester, and I'm going to talk a little bit about how we designed our hepatitis C elimination programme. And so really it ended up being 8 steps. It wasn't 8 steps to begin with, but when I think back, we had 8 steps in our designing, and then I'll talk about what the actual programme is. So, step 1 was really to get an idea of what we're dealing with, numbers. So I completely agree with the questioning that we just heard earlier on in terms of trying to get the numbers, trying to work out who is predominantly affected and who are the major transmitters as well. And that is an important thing if you're thinking about a population elimination programme, is to focus on the transmitters, not just those at highest medical need. And then once you've got an idea of who you're dealing with, who are these groups, what are their risk factors, what are their personalities, what do they end up doing, you really start mapping and scoping them. Who intersects with them? They're not going to generally come to you, so you've got to work out how you get access to them. Where would that be? When would it be? So we're talking about touch points, and that's a key aspect. Step 2, which sounds very brief, but it's actually one of the hardest bits, is to get rid of preconceptions. It doesn't matter how you've traditionally done things in hepatitis C or in any other field. What you should do is you should start with a blank piece of paper and think, what are the end results that we want? What have we got at the moment, and how can we get there? And forget about how you've done it in the past. It might be the right way, it might be the wrong way. There may be better ways. Step 3, in retrospect, was contemplate the simplest model. So it's quite easy, actually, when you're sitting down with a piece of paper to get these complicated models. Actually, simpler is best. And work out what are the incentives. Now, it could be financial incentives, it could be many other incentives to get people to engage, both staff but also the potential clients, with your initiatives. And you've got to realise this is a population programme and not a programme for individuals. So you don't need to find every single infected person to eliminate as a public health issue. And also, albeit we would love to, you don't necessarily need to provide gold standard healthcare for all. Obviously that's an aspiration, but what I'm trying to say is gold standard healthcare for every individual might get in the way of a population programme. Perhaps we'll touch on that. Step 4, remember what resources you have. In Manchester, we don't have a huge number of extra resources. We do have DevoMank, but it has less money than beforehand. How are you going to do this for minimal cost? And as part of that, really work out what does need to be done. What's absolutely vital and what's nice. And the nice might have to get sacrificed. Who's already there at these touch points who could do this? Have they got the skills? Do you need someone else? And if you do need someone else, exactly what skills do they need? And almost certainly it probably isn't going to be a band 6 nurse, band 7 nurse, a new consultant or anyone else who's much more expensive. Step 5, you sit back again and you work out how a particular initiative fits in with the other initiatives you may have on your piece of paper on your meeting. Look for synergies, look for unnecessary overlaps, again trying to streamline things, and try and get a comprehensive programme that really covers the bases you want without too much slack. Step 6, go back, look at everything. Are there unnecessary steps? Is it simple? Think outside the box. Get someone from a completely different field and background to look at your plans and see if they're sensible. Step 7, work out that what you originally started off trying to do, you're still trying to achieve. The aims are still the same. Have you covered those bases? And if not, go back again. And then step 8, the last step, is a word that I never used before, but socialise your plans. Go around your system, so London here, start socialising with all the different organisations what exactly you want to do. Get the important stakeholders pinpointed, knock on their doors, talk to them. Get them enthused, get them engaged. Build a team. Now for us, what was vital is getting the Academic Health Science Network, and you've got them in London as well, engaged. Their role is to start transferring innovation into clinical practice in the NHS, but also your local pharmacy committees, DevoMank. We have a whole variety of people. The university for the mathematical modellers. Get all these people engaged as part of a team. Start being a bit more professional than we are in the NHS. Business cases, Gantt charts, have people who know when things should be done by and how to do them properly, and then launch the programme so that all those stakeholders and everybody else know what you're doing, and it keeps the enthusiasm and keeps the momentum, or would do if we had access to the drugs in an elimination tender, which has got in the way somewhat. So, having said all that, that in retrospect is how we developed our plan. So what did we end up with? Well, this is the Greater Manchester Hep C elimination. This is Greater Manchester. We've had data for a while about where people live with hepatitis C, though we're not actually using that an awful lot, but that's a nice coloured map. So, this is the data we're given by Public Health England, and I do again come back to those questions beforehand because, this is what we're told. Just under 18,000 people with hepatitis C, a little bit over 10,000 diagnosed, and a few years ago, 3,000 had engaged with specialist services. Now, I can answer that we treat about 930 people a year in Greater Manchester, and if you assume good success rates, that's about 900 people cleared. So we know that. We've got some data about who's engaged, but the first two columns, very doubtful. So almost certainly similar data. So give me 30 seconds, I'll just say that's 17,450 there. The way that comes, if you drill down on it, is some estimates on how many drug users we have in Greater Manchester. What's the national rate of hepatitis C infection in drug users? Well, you do A times B equals C. And you do exactly the same for the racial groups, and you add them all up and you end up with this answer. So you're using national data and you're translating to estimates of populations within your area. And there are obviously going to be huge error bars behind that. So we do need better data. Come back to that in a bit. So who has hepatitis C? Well, for us, it's about 80–85% people who inject drugs. And those populations, people who inject drugs, are slightly enriched in people who are homeless and people who are in prison. So that's why we focus on those groups as well. MSMs, and then you've got racial minorities, and you've got a whole group of other people, as you'll all know, working in hepatitis C, that have hepatitis C that don't fit into these risk groups. Who are the likely transmitters? Well, it's the MSMs and it's the intravenous drug users largely, and so concentrating our programme, we're concentrating on these groups. We're not ignoring racial groups, we're not ignoring some of the other risk factors, but they're not the major emphasis. So what have we got? We've got something called a bedrock and 5 pillars, or 4 main pillars. So the bedrock is doing what we should be doing optimally. And we're not doing that. And actually, if you just do that, that gets you on the road to elimination. So by that, I mean, how many people in the drug services are tested? How many are retested every year or every 6 months? Do your drug services have some kind of risk algorithm that someone walks in and says, well, I'm not injecting, I'm just smoking now, or I'm just taking my methadone, and then they don't get offered a test? How ridiculous is that when we're talking about population screening, but we decide that someone saying they're not injecting as they walk into a drug service doesn't require a test? Of course they require a test, and they require retesting as well. Similarly, prisons. Opt-out testing in prisons. A lot of prisons are now somewhere between 15 and 20%. That's not opt-out. Opt-out's when it's 85–90%. So there's a lot of work we need to do. How many people are going to the homeless hostels? How many people are looking at these other risk groups and actually doing outreach testing and outreach treatment in those settings? So do what you should be doing optimally, and you're there. But in terms of the pillars, our first pillar, and one of our main pillars, is community pharmacies. So what we're doing in community pharmacies is we're highlighting about 60 community pharmacies around Greater Manchester who will do the whole package of care. They will identify people, they will test them, they will get access to the drugs, which in itself is an issue, they will treat them, and they'll do a test of cure. And those individuals will never see me and never see one of my nurses and never see anyone but the pharmacist. Now, how do we know that it's about 60 pharmacies? Well, we've got data looking at, say, opiate substitution, or we could do needle exchange as well. So this is just one of our CCGs, Manchester CCG, and we know that 80% of the methadone and opiate substitution therapy is provided from just 20 pharmacies. So we can focus on those 20 pharmacies and the needle exchange pharmacies. We don't have to do every one. We've got to be sensible about this. So that's community pharmacies. Network treating. At the moment, someone's diagnosed, gets engaged, bit of behavioural advice, hopefully treated, thank you very much, goodbye. What we're going to do is, before we treat them, we incentivise them to bring their network up for testing. And that not only gives us case finding of people we wouldn't find otherwise, but what we want to do is we want to treat that whole network at the same time, so that when people fall back to their risk behaviour, hopefully it's to a clean or cleaner network, and reinfection will be a bit less. And there's an example of network analysis, which we're hoping to do, and that's from Australia, hopefully going to do in Manchester soon. Interrogation of records. So we've got systems we're going to plonk onto initially primary care records looking for markers of hepatitis C risk, or people who actually have hepatitis C and it's known. And then when we have enough data, we're going to invite those people up and test them and hopefully treat them. When we have enough data, we're going to use reverse machine learning to develop an objective algorithm, because actually what I think might be sensible in a Delphi type exercise may not be actually a good way of doing an algorithm. Rapid prison diagnosis and treatment. We want to test people within, well, at reception or second reception to prison and start them on pangenotypics within 48 hours. And so we prevent transmission within prison and we have a virus-free prison. And that's what we're hoping for. Again, we got in the way because we don't have access to pangenotypics without a genotype, but we're working on it. And lastly, being scoped but not being activated, primary care and A&E testing. And why are we not doing that? Because we've just seen some data saying from viremic that it might work. Well, because it's quite a lot of work, it's quite a lot of money, but also I'm very keen on mathematical modelling and cost effectiveness, but that's looking at a program in isolation. And what I don't know is if we did something like that, how many people do we find who are unique to that pillar and aren't found in the other pillars? And I don't know that. So we're scoping it, we'll have it in reserve for if we're failing badly, and then we'll activate it. And around all this is informatics and data. Very simply, how can we talk about elimination unless we know where we are now, and then we can say where we are in 5 years and 10 years? We can't actually put our hands up and say we've eliminated. But also we need better data on what's working, what isn't working, and vitally, and people forget this, when to stop an initiative. When it's done its task. Everybody thinks about starting something, but actually you've got to think about when you stop something as well, because it's done enough. So, those are my thoughts. Don't let the perfect be the enemy of the good. And I think that's a really important quote when we come to elimination. People will say, are you not fibre scanning all your people? No, I'm not. We've got their data. A separate initiative can go around and fibre scan them, but fibre scanning might get in the way of the elimination. So I'm not forgetting about cirrhosis, but it's not the focus of what I'm doing. Thank you very much.